This is part 2 of chapter 39, and let's get started with GI and abdominal conditions. The first thing we're going to talk about is esophageal atresia and tracheoesophageal fistula. And the atresia is a blind pouch in the esophagus with or without a fistula, and the tracheoesophageal fistula can be found between the esophagus and the trachea. This happens in about 1 in 4,000 births, and about a third of these infants are born prematurely. On clinical findings, it's important to get a good history. Mom typically has had an overproduction of amniotic fluid. There's been the inability to put down an NG tube into the stomach during resuscitation, at birth, or arrival into the nursery. This condition can be suspected prenatally if mom has had large amounts of fluid or if there's a small stomach sac. On physical exam, you may note that the baby has a lot of oral secretions that require suctioning. The child may have issues with choking, coughing, may become cyanotic, especially during feedings, and there will be spitting and vomiting. Diagnostic studies can include chest and abdominal x-rays, and these may show that the NG tube is coiled in the pouch in the thoracic cavity versus going into the stomach. And this is something that's considered a surgical emergency and requires immediate intervention. The NG tube can be used to prevent aspiration, and some potential complications could be pneumonia, atelectasis, aspiration, strictures, repeated surgeries. Another GI concern in newborns, neonates, is a duodenal or duodenal atresia, and this is a complete obstruction of the duodenum. It ends blindly just before the ampule of Vater. It's associated with moms having excessive fluid. You can see it with prematurity and Down syndrome. Diagnostically, you would assess with x-rays of the stomach. Other differential diagnoses include a malrotation of the GI tract, obstruction, and an annular pancreas. Management includes surgery. Next, we're going to talk about a twisting of a loop of the bowel called a volvus, and this can cause intermittent or acute pain and an obstruction. Clinically, you're going to see abdominal distension and bilious vomiting. Plain films are used to assess the area. Differential diagnoses can include the annular pancreas and duodenal atresia. Management includes surgical repair and fluid replacement. Next is pyloric stenosis, and this is an hypertrophied pyloric muscle causing narrowing of that sphincter. This can occur in approximately 3 of 1,000 live births, so 3 out of 1,000 live births, and is 4 times more common in males than females. It does tend to be familial and is seen more commonly in Caucasian firstborn males. But on history, you're going to see that there's been a pattern of projectile vomiting for approximately 2 to 3 weeks. The child is going to have an insatiable appetite, but also noted to have weight loss and dehydration. It has also been associated with the use of erythromycin during infancy. Clinically, you'll see the weight loss, the non-bilious vomiting, may have blood. You may be able to palpate an olive-shaped mass in the epigastrium to the right of the midline, and you may note reverse peristalsis. You would order ultrasound or an upper GI series. Surgical intervention would be required after the baby has been stabilized with fluids and electrolytes, and then reintroduction of feedings would be gradually. Next, we're going to talk about Hirschsprung's disease, which is an absence of ganglion cells in the bowel wall, most often seen in the rectosigmoid region, which results in that part of the colon having no motility. It occurs in approximately 1 of 5,000 births. It is a familial disease, affects males 4 times more commonly than females, and is common in children with trisomy 21. Clinical findings are failure to pass meconium in 48 hours. There can be failure to thrive, poor feeding, chronic constipation. There can be distension of the abdomen, vomiting. These babies can have diarrhea and explosive bowel movements. Management includes surgical resection of the affected bowel, and it can include with or without colostomy. Next, let's talk about an imperforate anus, which is the lack of a rectal opening. So clinically, you'll have a child that has not been able to pass meconium. There's no obvious signs of a rectal opening. Ultrasound would be used to confirm. Management would require immediate surgical repair and may have long-term problems with bowel emptying. Next, let's talk about omphalocele and gastroschisis. Omphalocele is the protrusion of the intestines into the base of the umbilical cord and is often associated with anomalies. It can happen in 1 to 5,000 to 10,000 births. Gastroschisis is similar in appearance, but the intestinal contents are protruding through the abdomen with no protective peritoneal covering, whereas an omphalocele is the protrusion of the intestines into the spinal cord, with no peritoneal covering. Clinically, you'll see the sac-like protrusion. It's important with these little ones to maintain body temperature. Apply a protective gauze, and it will require surgical repair. Next, let's talk about necrotizing enterocolitis, which is necrosis of the mucosal or transmural sections of the intestine. Usually is in the first 2 weeks, but can be later in a very low birth weight infant. Clinically, on history, you may note prematurity, asphyxia, polycythemia. Mom could have had maternal hemorrhage, preeclampsia, exposure to cocaine. Clinical findings may include abdominal distension, vomiting, bloody stools, lethargy, apnea. There may be evidence of DIC that's going to move quickly into shock. To assess for this, you would do abdominal x-rays and a sepsis workup. Management includes antibiotics to stop the feedings and use suction to the GI tract. Would require surgical consultation. The mortality rate is anywhere from 10 to 50%, causing approximately 1,000 deaths per year. Next, let's talk about the meconium ileus, which is an impaction of the bowel with meconium, causing an intestinal obstruction. It's associated with cystic fibrosis, maternal polyhydramnios, and intestinal disorders in the infants. With these little ones, you'll see they will not pass meconium in the first 48 hours. They'll have persistent vomiting, abdominal distension. This can be seen in x-ray with the bowel loop showing variety of widths with a grainy appearance. Treatment will be individualized but could include enemas, or a laparotomy may be performed. Next, we're going to talk about a diaphragmatic hernia. It's where the abdominal contents herniate into the thoracic cavity. Clinically, you need to assess if there's been any respiratory failure immediately after birth. You may find that the baby has respiratory distress. You may hear bowel sounds up in the chest. Heart tones may be contralateral. Chest x-ray would be completed. Management would include having the infant positioned with the head in the chest higher than the abdomen, so gravity is pulling the GI contents back into the tummy. Intensive respiratory support and surgery to help reposition with intensive respiratory and metabolic support. Umbilical hernias are weakening of the umbilical ring or imperfect closure of that ring, and it's where there's some swelling in the umbilical area, and it is something that can be reduced. Management is dependent on the extent of it, but surgery is only completed if it persists past 5 years or if there's been an issue with strangulation. And it's important, though, to counsel parents not to tape coins over the site to keep that from swelling, is one thought. It can contribute to infection, but most of these hernias resolve by a year old, even though some may take a little longer. Okay, that's all we have for GI and abdomen. Let's talk next briefly about renal issues. So, acute renal failure is going to be urinary output less than 0.5 milliliters per kilogram per hour. And normal newborns usually produce between 1 to 3 milliliters per kilogram per hour of urine within the first 48 hours of life. There are many reasons why a little one may not produce enough urine at this time. Could include stress, dehydration, sepsis, anoxia, nephrotoxic drugs, hemorrhage, clot. Clinically, there's going to be a neonatal history of a decreased urinary output. The skin may be pale, there may be swelling, lethargy, there could be a high or low blood pressure. You might see pulmonary edema, CHF, arrhythmias. There also could be an abdominal mass or a myelomeningocele. Diagnostically, you're going to want to confirm that there is a urinary outlet. You would check a UA, osmolarity, sodium, potassium, assess renal function, check a CBC to include platelets. You're going to want to replace fluid loss, maintain strict I&O, assess electrolyte and fluid balance, monitor for pressures, and dialysis may be indicated. Next is hydronephrosis, which we know is dilation of one or both kidneys, possibly caused by obstruction of the uteropelvic junction, issues with the urethral valve. Clinically, could have been found on a prenatal ultrasound. It can be asymptomatic in the early stages, but you will note decreased urinary output and an abdominal mass. Surgical repair may be necessary. Cystic kidney disease, which would include multiple cysts of various shapes and sizes found in the kidney. It can be an autosomal dominant or an autosomal recessive disease. Clinically, you may find that the mom did not produce enough amniotic fluid. There could be an abdominal lobular mass. You could have hematuria, hypertension. Differential diagnosis includes a multicystic kidney, dysplastic kidney, hydronephrosis, Wilms tumor, or renal vein thrombus. Management includes maintaining kidney function. A renal ultrasound will be used to monitor for enlargement. It's important to assess for infection, control blood pressures, and dialysis or transplant if renal failure is found. So you can have, little ones can have renal artery or vein thrombus. So there's been some damage to the kidney that has occurred, clot has occurred, and now there's decreased blood flow. Clinically, there can be asphyxia, dehydration, shock, or sepsis. There'll be a sudden onset of blood in the urine. There could be a mass palpated. There can be enlargement of the kidney on ultrasound. Management includes fluid and electrolytes, monitoring the pressure, prophylactic anticoagulation may be needed for the clot. Nephrectomy is not usually needed unless there's issues with chronic infection or uncontrollable hypertension. Let's talk next about a neuroblastoma, a solid tumor with an unknown cause. The majority develop in the abdomen, usually in the adrenal gland. Clinically, there can be an unexplained fever. There may be a palpable mass. There could be ascites or firmness to the abdomen. The baby could be pale, have irritability, could be hypotensive. Tests to run would include a CBC, chemistry, x-rays of the renal system, ultrasound or MRI of the abdomen, assessing a skeletal survey, checking for urine catecholamines, and possibly a bone marrow biopsy. Management would include surgical removal followed by radiation or chemo, but sometimes they do regress without therapy. Next is renal agenesis, and this is the failure of the kidney to form normally in utero. Bilateral agenesis is incompatible with life. So clinically, on clinical findings, mom may not have produced enough amniotic fluid. If bilateral agenesis is noted, you would need may know also based on a prenatal ultrasound. Clinically, it may be associated with other anomalies in the GI, urinary tract, and the skeletal system. These babies may have low set ear, have a senile appearance, have a broad nose, known as the Potter syndrome. We need to monitor for proteinuria and hypertension. All right, next we're going to talk about some metabolic conditions. And the first is hypoglycemia. And in term babies, serum glucose rarely falls below 35 milligrams per deciliter in the first 3 hours. Okay, we had a pause and I was talking, so if this is redundant, I apologize. Let's start hypoglycemia back again. With term infants, glucoses rarely fall below 35 milligrams per deciliter in the first 3 hours, less than 40 in 3 to 24 hours, and less than 45 thereafter. Infants that are at a higher risk of having low blood sugar include a small gestational aged infant, those with diabetic moms, asphyxia at birth, sepsis. Clinically, you may find that the baby is lethargic, has regurgitation, a poor feeder. They may be jittery, pale, have cool extremities, or sweating. There may be seizures. Management of these infants is found on page 1107 in the chapter. Please review that. It's quite detailed. Next, we're going to talk about infants of a diabetic mom. And this can cause fetal hyperglycemia and fetal hyperinsulinemia, which leads to increased hepatic and glucose uptake. You may have a large plump baby. They may have puffy face. They can be hyperexcitable for up to 3 days of life. This is also shown in table 39-6 on page 1107. With these kids, cardiomegaly is common, as is heart failure issues, so those are important to be aware of. Next, let's talk about some orthopedic conditions. We're first going to talk about polydactyly and syndactyly. Polydactyly is a skin tag or a fully formed digit, and then syndactyly are digits that are fused by skin and bone. In approximately 30% of these cases, there's been a positive family history. Management includes surgical removal of any extra digit, and if there is a fused digits, then surgical separation. Moving on to the CNS system, let's talk about some congenital hydrocephalus, which we know is an overaccumulation of CSF in the ventricles. It can occur in 1 in 1,000 live births. We know that it can be seen in malformations, infections, intraventricular hemorrhage, and disorders of brain development. Clinically, you will note a rapidly enlarging head circumference and that the cranial sutures begin to become separated. Management includes medications and a VP shunt. So if these findings are noted, it's important to refer to a pediatric neurosurgeon promptly. Next is intraventricular hemorrhage, and this is bleeding into the ventricles of the brain and usually occurs in the first 72 hours of birth. Clinically, risk factors including small gestational age, prematurity. You might find that these infants have a diminished or an absent Moro reflex. They may have apnea. There can be cyanosis and pallor, failure to suck, a high-pitched cry, bulging fontanelles. Ultrasound is used to classify the intraventricular hemorrhage into grades 1 through 4. Treatment includes glucocorticosteroids antenatally to decrease risk, supportive care, medications to decrease CSF production, a VP shunt, and then outcomes will be determined by the amount of white matter involvement. Next, let's talk about hypoxic ischemic insult. And this is divided into 3 stages of injury, 1, 2, and 3, or mild, moderate, and severe. If you look on page 1109 in the book, it tells a little bit more about the particular stages and the impact that you will see with the baby. Initial hypoxemia can be followed by metabolic and respiratory acidosis. So the signs and symptoms are going to be dependent on the organs that are damaged. Approximately 15 to 20% of these babies die. 30% develop permanent disabilities. You may see pale skin, apnea. There may be cyanosis, bradycardia, but management is going to depend on the effectiveness of managing the underlying symptoms. And if there are severe complications or encephalopathy, that is consistent with a poor prognosis. Next, let's talk about myelomeningocele, which is a failure to close the posterior neural tube and the vertebral column. This is one of the more severe forms of a neural tube defect and occurs in 1 in 4,000 live births. Clinically, you may find that there's been poor prenatal folic acid intake. There may be a sac-like cyst containing the meninges and spinal fluid. There can be paralysis of the lower extremities. There can be absence of deep tendon reflexes and decreased sensation to lower extremities for touch and pain. Management includes a surgical repair, multidisciplinary support. Our next section is going to be on hematologic conditions, so let's end out this video and come back for part 3. Thank you.